Like, for example, for me, starting on internal medicine, like, I don't really have anything to compare it with, right? So,
And I was the same as you. So I started my CC3 on internal medicine. And at the end of those 8 weeks, I'm like, I don't want to do internal medicine.
This is The Rounds Table.
All right, welcome back, Roundtable listeners and MedPods listeners. A very different style of episode. I find Roundtable skews more towards residents, staff physicians, but we're going to be, making a throwback, aka a throwback to maybe when I was a med student. I'm joined today with Mihir Pandya. He's a CC3 in London at Western. And we thought we would just have a conversation about clerkship, internal medicine, how to prepare for your rotation. Really, Mihir, you can ask me any question, and I swear we won't have our editor edit things out. Do you want to introduce yourself to the listeners?
yeah, sure. So, yeah, as said previously, my name's Mihir. I'm a third year clerk here at Western University in London, Ontario. Not 100% sure what I want to do, but was definitely leaning towards internal medicine. And in fact, I'm actually on internal medicine right now.
Cool. So, I mean, the timing works out well. So, Mahir, as you were preparing for the rotation, what questions were circling in your mind, or what questions are still circling in your mind?
Yeah. The one big one was just how to prepare in the sense of there being so much content throughout internal medicine. You'll see so many different kinds of patients. Yeah, just how to gather all of the knowledge that is required to be an effective clerk before the rotation, and even having the time to study and fill those gaps of knowledge while you are going through the rotation, since it is so taxing.
Yeah, I agree. So, the first is to just lower expectations for yourself. There's way too much information to know, and you have no clue what condition or conditions your patients are going to have. So,
Right.
it's really challenging. And I think instead, what's more useful is to think through what are some approaches? What are some approaches I might have to common problems? So, some people have a photographic memory. I'm not one of them. And for me, I find it's way easier to remember things if I instead am thinking through, okay, like, what's my approach to an acute kidney injury? Pre-renal, renal, post-renal. What's my approach to heart failure? Are they in heart failure because of, I don't know, they haven't been taking their medications? Are they in heart failure because they also have a myocardial infarction? As I say those things out loud in here, that's actually not an approach. That's just me rambling. But so, number one, set expectations lower for yourself. There's no way on earth that you will feel prepared when you start your internal medicine rotation as a CC3. And as a staff physician, like spoiler alert, I don't really care how much the CC3s know. Instead, I care way more that they're learning everything about their patients and that they're taking really good care of them. So that's one piece of it. I know you also mentioned the rotation is taxing. That is so true. And how do you keep up, or how do you learn things as you go? It's challenging. I think one thing that I found helpful is, passive ways of learning, whether or not that's listen to a podcast, whether or not that is something a bit more light touch, and then you can sort of do it on the go. But the truth is that it takes a really long time, an extremely long time, before you feel like, okay, I'm comfortable with this wide breadth of knowledge that is internal medicine.
Yeah, that's reassuring to hear because, upon starting, seeing all the residents, finishing rounding and and writing notes in like 2, 3 hours, while I'm still stuck typing away, can feel a little daunting at times.
Yeah, of course, 100%. And I also think like your goal should not be, I want to be efficient by the end of my rotation. God, no, right? Your goal at the
Hmm.
end of the rotation is really to know, as you look at the residents, as you look at the staff physicians, is this something that appeals to you? You know, like, is this something that you want to do for many more years to come? And I think the other aspect that I hope a clerk has by the time they're done their CC3 year is they're a lot better at taking a history. But I kind of found it wasn't until I was like midway through R1, and then I really knew how to take a good history. So, yeah, a lot of it is sort of recalibrating expectations and instead, not that I want to learn everything, but I want to leave with having some good approaches. And people say this, and it's become, I guess, maybe it's said too often now, but it is really true to read around your patients. And even me as a staff physician, I'm seeing patients with conditions I've never heard of before. And when I learn about those conditions, I'm learning about it because I want to be able to deliver really high quality care to the patient in front of me. And it's also a great way to learn and remember it. So, although it's sort of, maybe a bit of a cliche, it really is true that when you see a patient with a condition, that's the time to then dive into that topic, read about it, because it'll be much easier for you to remember it after the fact.
Yeah, yeah, for sure. That makes a lot of sense. Another question that I had for you, kind of building on what was discussed previously, is to build that good relationship with a patient that requires a lot of effort. And that's something that I find a lot of my fellow classmates in third year, just starting off with internal as well, kind of struggle with at times. So, do you have any tips for us in terms of how we can build a better rapport with patients and get a fuller, complete story of what is going on in their lives?
Yeah, I think the basics go a really long way. So I say the same thing to the clerks when I'm on service. When you're at the bedside, like find a chair and sit down. Be at eye level with the patient. If you stand up, they'll just feel like you're rushing them, even if you don't mean to be rushing them. So take a moment, find a chair, sit down, and asking them like some really basic questions goes a very long way. So some of my go-to questions are you a tea drinker or a coffee drinker? Okay. Do you have grandkids? Now, you don't want to ask somebody, do they have grandkids? If like they look like they're my age, okay. Um, um, and
Yeah.
my parents are now grandparents, and I've realized grandparents love talking about their grandkids more than absolutely anything.
Yeah.
And then I usually share something with them as well. So if I walk to the bedside and I see they got like, I don't know, a bag of chips and like a Twix bar or something, I'm like, oh, you got a sweet tooth just like me. So really little things like that, forming those connections, I think that's what builds rapport. And other basic things, you got to talk slowly. And I remember being a clerk and I was nervous. So I was probably talking really quickly, but trying to talk slowly and avoiding jargon. In internal medicine, it's almost like learning a whole other language. And as a clerk, it takes so long to learn that language. And then you learned it. And now you're talking to the patient about their ACS and their CHF and and they have no clue what you're talking about. So I really try to do those things. Some of the things that I've seen other staff physicians do that I've always wanted to do, but I haven't, is like some of them will like, they'll have like a sheet that gets printed out and it says like, I'm your doctor and this is the clerk and this is the resident. I really like that. The problem is that it's just sometimes hard to sustain that. But I really like, and I've seen staff physicians do that, and I think that's a really nice move as well. So to recap, when you're talking to a patient, make sure you're sitting down. Make sure you're talking slowly. You gotta be avoiding jargon. It's useful to repeat things. The same way I repeat teaching points to CC3s or R1s, I repeat points to my patients. Take an extra moment and actually write something down for them. That's super useful too. I'll share a story with you. Um, when my mom was hospitalized, I remember the surgical team were rounding, and even though and I think at that point I was like a second year resident, third year resident. So I was a third year resident, but it's like you actually get kind of nervous when the doctors come by.
Yeah.
The surgeons spoke quickly and didn't write anything down, and then they left. And I feel like neither my mom nor I remembered much of what they said. So, I will sometimes write things down for patients because I think it goes a long way. And it's all of those little things. It's those very, very little things, which, take it from me. That's what makes a difference towards building rapport. And maybe the last point, and then I'll let you go on to whatever the next question is. But I say this and I mean it sincerely that when I'm on service, I want the trainees to walk away realizing or me imparting on them that we should treat our patients the same way we'd want our loved ones to be treated. So with that in mind, and sometimes it's hard and you're exhausted and you're post call or you're sleep deprived, but just asking yourself, if that was my mom, what would I do? You know what? Okay, I'm gonna go back to the bedside. I'm gonna go re-explain things because that's what I'd want for my mom. So that's the other lens that I try to see the patient's experience through.
Yeah, yeah, no, that makes a lot of sense. I think it's just hard to conceptualize sometimes when, at least for us in third year, I feel like I'm kind of pressed for time. And so having these meaningful conversations, which are of course super important, they just sometimes feel difficult because there's just so little time that I have in a day with all of the stuff that I have to finish. Yeah.
Totally. Yeah. And even sometimes I feel that as a staff physician, I'm like, oh man, I got so much stuff to do today. Um, I think it's easier as you go further along your journey because then you sort of know when is the right time to, put the foot on the brakes and when is the time to speed up and also how to become efficient. But if you take away nothing from this conversation, one thing to definitely take away is just sort of asking those basic questions can really be helpful in building rapport with a patient.
For sure, for sure. Another question, and this may be helpful to even residents, I think, but throughout medical school and even past that, oftentimes students have to get letters of reference from staff, and that can seem like a daunting thing. Maybe people feel a little awkward about it too. So I was just wondering if you have any advice, being someone that has gone through the process and has written letters for other people as well. What could you say to maybe ease that anxiety, or if you even have like an approach that you could suggest for
Yeah.
students to ask those letters?
Yeah. So as staff physicians, it never surprises us when a student asks for a letter of reference. So don't worry about that, I guess. I'm not sure how helpful that is, but like as everyone like, oh man, they're asking for a letter or a reference. Can I like, no, no, I expect that. And I certainly think when it comes time for your electives, when you're a fourth year med student, or maybe you do them in your third year, it's super useful at the start of the elective just to say to the staff, hey, I'm actually really interested in internal medicine. I'm hoping that if this rotation goes well, to ask you for a letter of reference. And it would be great if maybe we could touch base a few days into the rotation to find out, what am I doing well and what should I be working on. When trainees say that to me, I'm just like, whoa, like that's super mature of them. Okay, yeah, 100%. Like I'm engaged, like I'm expecting it. So it's very, very fair to say that. Or if you're on a rotation, it's a core rotation, and you're like, man, I love this rotation. It's also completely fine to say, hey, I'm actually thinking about becoming an internist. And, it would be great if you feel comfortable writing a letter of reference for me because like I'm really enjoying this and this, that, and the other thing. So just open it up, having that conversation. Some staff will say to the trainee, like, hey, like, I want to write you a letter of reference. That's extremely rare, okay? So don't worry if that doesn't happen for you. But the short version is just that it's something I totally expect that some students will ask. There are some students that I can tell from day one or day two, they want nothing to do with internal medicine. And I'm okay with that. Usually the tell is that they come late to rounds. they're flipping through Instagram as I'm attempting to teach them about some condition.
Okay.
So, not all trainees are coming to their internal medicine rotation and wanting a letter of reference. And when we see trainees that are engaged, they care a ton about their patients, you can tell they're going the extra mile for them, they're reading around their cases, then it just becomes so natural that, oh, of course, Mihir's probably going to ask me for a letter of reference.
Yeah, yeah, for sure.
And Mihir, one other thing before I forget, and like when you do ask someone, especially if like a long time has gone by between maybe the rotation when you ask them, if they like attach their CV, I find that super useful. I'm like, hey, I'm here. You maybe don't remember me, but I was a CC3, and now I realize I really want to do internal medicine. I'm emailing you because I want a letter of reference. Like, if you're comfortable writing me a letter of reference, I've attached my CV, or like, I'm happy to draft a paragraph on why I want to do internal medicine. So those little things, when I get an email like that and the trainee has made my life easier by like, here's a blurb on why I want to do it and here's my CV, that helps to smooth out the process as well.
Yeah, no, that's a great point actually, because I find that that's something that often happens where people go through, clerkship and then over time realize they enjoyed some rotations more than others. And so,
Yeah.
like for example, for me starting on internal medicine, like I don't really have anything to compare it with, right? So,
And I was the same as you. So I started my CC3 on internal medicine. And at the end of those 8 weeks, I'm like, I don't want to do internal medicine. and then and then I did surgery and I'm like, there's no planet where I want to be a surgeon. We have very few surgeons who listen to this podcast, so I won't get any angry emails.
that's fair.
And then I did a merge, and I thought for sure I want to do a merge. And then I did the rotation. I was like, oh, geez, you know what? I don't think I want to do that. And so for me, it wasn't until the very end of clerkship when then in retrospect, I was like, oh, I actually do want to do internal medicine.
Yeah. And on that note, did you then gear your electives towards internal medicine and started getting reference letters in your fourth year?
Yeah, so I remember reaching out to some of the people that I had worked with like 8 months before, being like, "Hey, I hope you remember me because I'm emailing you because I want a letter of reference." And then for my electives, I did 3 weeks in Northern Ontario in family medicine, which I really enjoyed, and then a variety of other subspecialty electives. I did a med-onc one, I did a cardio one, did a couple others that I can't remember. So that's where I got some of the letters of reference. And the thing about internal medicine is that it's not like it's relatively competitive, but it's not like dermatology or plastic surgery. So I try to reassure trainees that, listen, even if it wasn't until later on you realized you want to do internal medicine, and even if your electives are some family medicine and some internal, and I don't know, maybe a psychiatry rotation, like that's okay. That doesn't mean you're not going to get in. Whereas if you want to be a dermatologist, no, that probably will not. So, internal medicine is sort of middle of the road for competitiveness. So I think it's completely fine if people don't realize until later. And it's also A-OK if you don't have every single one of your electives in internal medicine or a subspecialty. That's okay.
Very reassuring to hear, I'm sure. For me as well as hopefully the listeners.
Yeah.
But yeah, okay, on to my kind of last question for this episode. Us clerks, oftentimes I feel like we can kind of see attendings in a very kind of superior we put attendings on kind of like a pedestal to the point where it's hard to see how we are able to get up there after so many years of training. And so maybe to bring that down a little bit, for lack of a better word, can you kind of talk about how you have learned over all of these years of training, and even if you have kind of like made a mistake once, and how you shaped yourself from learning through that?
Yeah, I can remember when I was a CC3, like seeing these residents, and I'm like, oh my God, how do they know so much? And the staff physicians, you're like, oh my gosh, like I will never, ever be anywhere close to that. But there are some biases in there. So, some of the biases are as staff physicians, we aren't going to talk a lot about the things we don't know. We're going to talk about the things we do know. And when we're on rounds, we're going to teach points that we know. That's why we're teaching them. So, your staff physician doesn't know everything. They're fallible. I have to look things up all the time. And I also have a roster of past residents who have now become a dermatologist or an ID doctor or whatever. And I'm texting
Right.
you when I'm on call at Sault Ste. Marie and it's 2 a.m. like, hey, Derek, like, does this condition present like this? So you don't see a lot of that, right? So you get a biased sample of what reality looks like. And certainly as a staff physician, I've made mistakes before. I used to give teaching rounds called Mike's mistakes, really to normalize that even as a staff physician, you do make mistakes. And sometimes those mistakes can lead to bad outcomes. And that is a part of medicine. I also think that sometimes bad things happen regardless of what we did or did not do. And most of us in medicine are type A, and we assume it must have been because we did something wrong. And I mean, I hope if you talk to a resident that recently worked with me, they will tell you that as we're running the list or we're reviewing new consults, I try to make a habit of saying, oh, you know what? When I was in R2, I actually didn't know this presented like that. When I was a staff physician, I actually remember missing this diagnosis, and here's why I think it happened. So I really try to make an effort of just sort of removing that pedestal and normalizing the fact that your staff physician is not all knowing. Yeah, yeah, and anyway, so yeah, but I can relate to that so much so, and even to be honest, like sometimes as a staff physician, I think to myself, oh man, like what would Ophir Murad do? And he was this outstanding internist, such an incredible diagnostician. So even as a staff physician, I sometimes think, oh man, what would they do in this scenario? And not infrequently, I will text them or email them. So, I have those individuals who I reach out to where I feel like, I actually don't know what's going on here and I need some help.
Yeah. It's good to know that the feeling never really goes away.
It gets better. It
It
gets
gets
better over
better.
time. And also I think there's a demystification in the sense that so much of medicine is actually like just pattern recognition, but it takes a long time to learn those patterns. As I say to some of my graduate students in my lab who are like doing a master's in computer science, like that stuff is hard, okay? That stuff I could never understand. Medicine, it's challenging, but it's pattern recognition. It just takes a really long time to learn those patterns. Well, anyway, Mihir, it is almost my bedtime. I have a question for you, Mihir. What do trainees use as they're trying to look something up or learn something? Is it all ChatGPT these days, or what are the resources that trainees are using?
Yeah, a big one that's been kind of advertised to us by other residents and sometimes even attendings is open evidence is
Yes.
what it's called. Yes, open evidence is the better chat GPT from what has been told to us. I know a lot of medical students also buy Amboss subscriptions, which helps them with shelf exams and sometimes when you are just trying to look something up really quickly, I've heard it's a helpful resource at the same time. And then kind of just your regular old like Google search.
Yeah, going old school with Google.
Yeah, good old school Google.
Yeah.
Um, yeah, there are some university subscriptions that are built into Dynamed, for example, over here at Western. Students get access to that. I'm not too sure if other schools have up to date. That's one that I've seen a lot of residents use as well.
Yeah.
Um, but yeah, to summarize, like the biggest ones are right now definitely open evidence, and then Dynamed, I would say, is another big one, and then on occasion you'll see people using AMPOS. Yeah.
Cool. All right, Mihir. Well, how many weeks left do you have of your internal medicine rotation?
I have 2 weeks left. 2 weeks left. Yeah.
Okay. Hang in there. Hang in there. Okay. You're almost done. You're
Thank
almost
you.
almost done. Like clerkship does fly by pretty fast. So I know it's stressful, but try to have a fun time as well. It's sort of one of the only times in your journey as a physician where, 1 week you're an internist, the next week you're helping remove an appendix or something like that. 2 months later, you're delivering a baby. So that actually is it's a pretty special and magical time. Although I realize it's also stressful. But anyway, Mihir, great to chat. Hopefully you learned something new, and hopefully the listeners did as well.
Yeah, of course.
Okay, take care.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.